What if I told you that most students get chest pain wrong, not because they don't know enough cardiology, but because they're thinking about it the wrong way? Chest pain is not a localization problem, it's a risk stratification problem. And if you treat it like a localization problem, sharp versus dull versus burning versus pressure, you'll miss the diagnosis that actually matters. In this video, I'll show you how to immediately identify dangerous chest pain, the pattern that predicts stable angina in seconds, and the exact framework you can use on exams and in OSCEs. When a patient says chest pain, don't start with the diagnosis. Start with asking two questions. Could this kill them? And what do they mean by pain? Your first job is safety screening. So you want to look for red flags like pressure or crushing pain. Is there radiation to the jaw or an arm? Shortness of breath, diaphoresis or nausea? Presence of syncope or abnormal vitals? Any sudden tearing pain? Or pulmonary embolism risk factors? Because if you miss these, that's what actually harms the patient. So our clinical goal here is simple. Chest pain is not a localization problem, it's a risk stratification problem. So let's see how we can apply this framework to our 54-year-old male whose chief complaint is chest pain. Okay, let's look at our initial DDX list for our 54-year-old male with a chief complaint of chest pain. Before narrowing, we build a structured differential. So we have life-threatening conditions like acute coronary syndrome, aortic dissection, pulmonary embolism, tension pneumothorax. There could be cardiac issues that are non-ACS, such as stable angina, pericarditis. There could be pulmonary causes like a PE, pneumonia, pleurisy. We also have GI, so we could consider GERD, esophageal spasm. There could be costochondritis for MSK, and then other like anxiety. We'll narrow this down using pattern recognition. This is the key step. We want to ask, what kind of chest pain is it? If there's pressure or tightness, that indicates cardiac cause. If it's sharp or pleuritic, more likely pulmonary. If there's a burning sensation, it's more likely GI. And if it's reproducible, MSK. But here's the next deeper layer. What pattern does it follow? Is the pain exertional? Indicates cardiac. Is it positional? That's more likely pericarditis or MSK. After meals, GERD is a likely cause. Sudden tearing could be vascular. So pattern predicts pathology here. Here's some questions we'd want to ask to assess an action framework and the exertional pattern. If any of these are yes, that's indicating a stable angina pattern. And then you might wonder, when do I get an ECG? You could use that if you suspect cardiac cause. You might then ask, when do I do a stress test? You'd only want to do that if they're stable. And then lastly, when would you send someone to the ED? That would be if there's any positive red flags. And don't forget, clinical pearl, that pattern predicts pathology here. Now, let's zoom out for a second. And remember when I said chest pain is a risk stratification problem? Well, here's our risk pyramid. Chest pain lives in three patterns. Emergency pattern with ongoing pain, hemodynamic instability, and new neurological deficits. We could have a slightly less concerning but unstable pattern where the chest pain occurs at rest, there's increased frequency or severity, lasting more than 20 minutes, and it could be associated with diaphoresis, nausea, or syncope. And then at the bottom, lowest risk is our stable pattern, where we have predictable with exertion, pain might be relieved by rest, it's short in duration, and it's the same threshold each time. So your job is to place the patient in one of these buckets. I've created this algorithm to help you systematize your approach to chest pain. So first we'd want to ask if the patient's stable. If they have pain with rest or it's worsening, then we'd want to send them to the ED for an ACS workup. If the pain is exertional but relieved with rest, that's more likely to be stable angina. If it's non-ischemic pain and they're stable, it can be three different categories, and so we can use pattern classification to help us. So if there's burning, postprandial, or lying down pain, that's more likely to be GERD. If it's reproduced with palpation, that's more likely to be an MSK cause. And if it's a sharp or pleuritic pain, we'd want to be more concerned and have them be evaluated for pneumothorax or a PE. Okay, so now we're ready for our 54-year-old male. He presents with intermittent chest discomfort for 2 weeks. He He describes a pressure-like sensation at the center of his chest that occurs with brisk walking and improves with rest after about 5 to 10 minutes. The pain does not worsen with palpation or deep breathing. He denies fever, cough, or a recent illness, and he has a history of hypertension and hyperlipidemia. He is a former smoker as well. So now we have some information that we can update our initial DDX list. So based on this patient, we know his pain is exertional, it's pressure-like, it's relieved with rest, and it's a consistent threshold. So I'm thinking my most likely working diagnosis is going to be stable angina, but I'm going to also keep GERD and costochondritis as my top working alternatives just to make sure we don't have premature closure. But we can use our physical exams next to help us narrow that down and rule out any dangerous causes. In an OSCE exam, your goal is to assess for stability and support or refute your differentials. So don't forget key exams like vitals, general observations. The point is you're using your PEs to be informed by your working diagnosis and your top differentials, as opposed to just a spaghetti mess and hoping something works. You want to show a targeted approach. So let's dive into our potential DDXs with this table here and how that might look for our example patient. So if we're suspecting stable angina, we'd want to look at heart exam, check vitals. We'd want to look for any kind of normal pain between the episodes. So for this patient, everything was within normal limits. To assess for acute coronary syndrome, you'd probably need an ECG, but you definitely want to check vitals. If that was the diagnosis, then you'd probably see an abnormal ECG, there'd be ongoing pain, and the patient would be unstable. So for our case today, that's not the situation, and the vitals are stable. If there was pericarditis suspected, you definitely want to do a heart exam. You'd want to listen for a friction rub and any positional changes in pain. For our patient today, no positional pain was noted and there was no rub. For a pulmonary embolism, want to check vitals, probably want to do a heart and lung exam as well. We'd look for tachycardia, hypoxia, making sure that the lungs were clear. So for our case, we had normal O2 and no tachy. If there was pneumothorax, you'd obviously want to check the lungs. You'd look for decreased breath sounds and any asymmetry. And so for our patient today, the lungs were clear to auscultation bilaterally. If GERD was the cause of this patient's chest pain, you definitely want to do an abdominal exam. I still think you should still do a heart and lung. But if GERD was present, there'd be epigastric tenderness, postprandial pattern would be present, which isn't the case for our patient. And then lastly, costochondritis. You'd have chest wall pain with palpation, so you could reproduce that tenderness. And again, we have normal O2, the patient's not tachy, and there's no pain reproduced with palpation. So it looks like we're leaning towards stable angina. So now that we've gathered information from our PEs, let's revisit our patient and how you might present your assessment. So we have a 54-year-old male who presents with a 4-month history of exertional, pressure-like chest pain lasting 5 to 10 minutes and resolving with rest. He reports mild dyspnea without syncope, palpitations, or pleuritic features. He has multiple cardiovascular risk factors, including hypertension and hyperlipidemia. In-office vitals today showed signs of he was stable. Physical exam is unremarkable between episodes. So his clinical presentation is most consistent with stable exertional angina. Your plan could include cardiovascular risk stratification, ECG evaluation referral, consideration of a stress test, risk factor optimization, and patient education on warning signs requiring urgent evaluation. Before we wrap up, I wanted to go over 3 common mistakes students make with chest pain as a chief complaint. The first is anchoring on pain quality. Burning does not exclude ischemia. Pattern outweighs descriptors here. Number 2, ignoring risk factors like age and comorbidities because these matter. Pretest probability changes your threshold here. And third, premature closure. Exertional pain equals ischemia until proven otherwise, and multiple conditions can coexist. So before finalizing, be sure to ask, what dangerous diagnoses have I not ruled out? Let's review the ScrubNotes chest pain framework. Safety first. Be sure to rule out ACS, PE, pneumothorax, or dissection. Patterns are key here. Exertional plus relieved with stress is more indicative of stable angina. Rest pain or worsening is unstable. Sharp, more likely pulmonary. Burning, most likely GI related. And reproducible, MSK is a strong contender. So risk factors matter as well. So age, with hypertension, hyperlipidemia, and smoking all increase probability. The bottom line here is chest pain is a risk stratification problem. If you're preparing for OSCEs or clinical exams, I've linked a couple high-yield resources below. I love Dane's assessment. That's like the OSCE book. There's also a short OSCE pocket guide to help you with exams and refreshing when you have short breaks. And if this framework helped, check out the full chief complaint list, where we apply this same system to syncope, palpitations, shortness of breath. It's the same framework, just different complaints.